Well, good afternoon. Welcome to everybody who decided to join Sano seminar on computational medicine. It seems that we already have a more or less stable number of participants of this seminar. So today we have one of these Sano seminars in the cycle. PhD student presents their research, and today we have as a speaker Joanna Kaleta, who is a PhD student at Health Informatics team, and Joanna was promoted from as a Master of Science from Warsaw University of Technology, and now is working with us at Sano, and he's trying to find solve problems of generative modeling and bridging the gap between simulation and real medical data. But it's just a short introduction, and Joanna is a member of Health Informatics team, which is led by Przemysław Korzeniowski, and Przemek, well, will tell more about Joanna and her research. Przemku, screen is yours.
Okay, thank you very much, Marian, for the introduction. So that's correct. So together with Asia, we are looking at basically generating synthetic but realistic images based on my simulators. So in other words, we get the 3D image from the simulator, a color image, endoscopic image, and because of this, we can also generate all sorts of ground truths like depth maps, normal maps, optical flow. We can have all sorts of labeling, additional labeling, and this is very important because such data, for example, surgical footage, is very difficult, tedious, and costly to label manually because simply because we need experienced people like surgeons to do it. And there is a big issue, big problem in the community with lack of labeled data. So together with Asha around 2 years ago, I had this idea how to combine my simulation work with artificial intelligence. And that was around this time the stable diffusion models came out. And apparently that was very successful because that was Asha's first publication in International Journal of Computer-Assisted Radiology. But also this work was awarded Best Student Paper Award at workshops on diffusion models at NeurIPS in December 2023, which I guess it's a very good start for a PhD project. Yes, so Asha now is also continuing with this work, but she's also at the doctoral school at Warsaw University of Technology, where she's also looking at basically Gaussian splatting and neural rendering aspect. Okay, thank you very much. That's all.
Thank you very much for this introduction. And as usual, we will have talk of Asha. If you will find that it's completely necessary in order to understand what follows to ask a question, please do this using a chat or a question and answers. And I will try to transfer this question to Asia. And of course, after the talk, we will have, as usual, discussion and regular questions and answers. So, well, after all of these starting procedures, information, as you floor, I mean, screen is yours.
Thank you. Thank you very much for the introduction. So good afternoon, everyone. Today I have a pleasure to present to you an overview of my research conducted at Sano. So the plan for this presentation is as follows. First, I'm going to discuss my first project, synthetic data generation, SynthReal, which Przemek briefly described during the introduction. Then I'm going to present to you my second project, which is semi-supervised self-explanatory learning using also diffusion models. And then, as the last part of my presentation, I'm going to very briefly discuss for you the potential of novel view synthesis for surgical operations, because this is my my recent research area. I started a couple of months ago. So my first project, synthetic endoscopic data generation with stable diffusion, as Przemek mentioned, is already published in IJCARS. It was also awarded at Nurik's workshop, which indicates that this project is of huge importance in medical community. So let's start with a little medical introduction. Laparoscopic cholecystectomy is a common and minimally invasive medical procedure for gallbladder removal. And like other endoscopic procedures, it faces technical challenges due to limited visibility and the usage of multiple instruments, which may lead to potential complications. And for that reason, it benefits greatly from the computer-assisted intervention methods. There are several deep learning applications, such as identifying safe dissection zones, action triplet recognition, temporal modeling, and tool segmentation to address these laparoscopic cholecystectomy complexities. And as you may realize, deep learning requires lots of data. However, labeled medical data is hard to get for several reasons I listed here, and often can become a major bottleneck in developing machine learning proof of concepts. So to solve this problem, we can obtain training data from domain-specific simulators. However, this data is not very realistic. In this work, we aim to generate realistically looking synthetic data based on available simulation data. The generated data should be consistent with corresponding maps, such as segmentation, depth, or normal maps. We created a method which uses only minimal real data for training to address the common problem of medical data scarcity. So we base our work on the popular Stable Diffusion model. It is a state-of-the-art generative text-to-image model. However, general purpose models have very limited knowledge about surgeries. So here we try to generate endoscopic images with the original Stable Diffusion. We can see that the model lacks domain-specific knowledge, and manipulating the text prompts leads to really weird results. And to inject such knowledge to Stable Diffusion, besides traditional very costly fine-tuning, it is possible to use smart fine-tuning alternatives. And in our work, we use DreamBooth, which is a method of model customization. DreamBooth requires only limited number of training data, and it allows to introduce a new concept to the diffusion model. It can be object or style. In our training scheme, we use less than 100 manually selected real images, and as a result of DreamBooth training, we obtained a fine-tuned Stable Diffusion model able to generate endoscopic images. And the key element during the inference process was the consistency with all the corresponding maps. And to achieve this, we utilized ControlNet, which is an architecture designed to control large diffusion models by incorporating additional conditions, such as sketches, key points, edges, or segmentation maps. And we infer data in image-to-image mode with ControlNet model support. As a result, we get really realistic and consistent images. We compared the generated images with the raw simulator images, and we show the results show high realism and accuracy. And we also compared our rendering with GAN baseline. And it is worth mentioning that for the GAN-based method, authors needed around 70,000 of real images for training, while we use less than 100 images for each style. And we can see that the overall level of details is preserved, tissues and tools are realistic, and they are in proper places. So I think the goal was achieved. So we also performed quantitative analysis. We calculate rigid inception distance to compare similarity between real and synthetic images. We see that our method keeps very similar or even better score compared to the GAN baseline. And we also evaluated our data on the downstream task, segmentation, and our method achieved significantly higher intersection over union score comparing to the baseline, which means that our data was not only realistic, but also tools and tissues were really properly placed. And the extension of this work was recently took over by Sabina Kamińska as a first author. And now the goal is to utilize fully fledged, much more realistic simulator with wide range of interactions. And you can see in this image that the real data, which are in the top row, and the simulated data at the bottom row are really difficult to distinguish which are real, which are synthetic. So this is the goal with the new simulator developed by Przemek Korzeniowski. And the pipeline is also improved thanks to more flexible. Thanks to LoRa, which is low-rank adaptation. It is lightweight and composable Turfel model fine-tuning. And this work was submitted to Winter Conference on Computer Vision. Okay, and that was the very brief summary of my first project and the extension of it. And now let me introduce to you my second project, MediFusion, which is also built on diffusion models. And let's refer to the same slide again. So synthetic data creation is not the only way to leverage generative models to deal with data scarcity in the medical domain. And this time, I also want to address some of the listed challenges, however, from a bit different perspective. So the main idea for this project is to utilize shared parameterization of latent diffusion and classifier model. We use unlabeled and labeled data to train the diffusion model to obtain a rich representation in the unit. And then we use only labeled data, which is a much smaller part of all data, to train the classifier module on features extracted from the unit. And the whole model is trained jointly. And such reparametrization benefits the model in the following ways. First, learned representations work really well in semi-supervised classification scenario, where we only have very small percentage of labeled data. Second, the model is capable of generating synthetic data, just like a regular generative model. But the most interesting property of this model is the self-explanatory part. We use our trained classifier to guide the generative part, so the desired class is generated. So it allows us, for example, to remove specific class from image with disease, which gives us some kind of counterfactual example, some kind of explanation why this part of the image is really important to recognize the disease. The model architecture is quite straightforward. We use latent diffusion because medical images like X-rays usually are of a very large size, so we want our model to be effective and work quite quickly. We pull features from unit H space, as you can see in this image, and simply pass them to the MLP classifier. The classifier guidance part is not a part of an architecture. It is rather a technique to manipulate the denoising process in the generation part. And now the results for classification show that our model is comparable with the most recent semi-supervised models. specialized only for classification, only for semi-supervised classifications. Also, we don't need long pre-training on ImageNet data to obtain such similar results. And we can say that our approach is orthogonal to pseudo-labeling or consistency-based classification methods. And here you can see how we make use of classifier guidance for our counterfactual example generation. Bounding boxes indicate the area affected by a disease. We noise sample by, let's say, 20%, and then guide the model to generate sample without the disease class. We can see that the original sample and generated sample have the biggest absolute difference within bounding boxes. So now the crucial evaluation was to investigate whether the changes introduced by this classifier guidance are really local. And in fact, pixel changed the most within those disease bounding boxes I showed you in the previous slide. And that confirms the locality of disease removal. And it's worth to mention that this type of classifier guidance can be applied to model trained on any percentage of labeled data. So for example, here we use only 2% of labeled data, and we still can see that the model is effective and the changes are very local, which means we can explain the model trained even with a very small percentage of labeled data. And by testing those counterfactual examples with external classifier, we showed that only the prediction for the desired class changes significantly, which is the exact result we want to achieve. So we only want to remove one class while keep the predictions for the remaining classes, that was multi-label case. We want them to stay more or less the same. And we showed here in this study that in fact we achieved this goal. And it is really worth to mention that classifier guidance works really well both ways. So we can also generate synthetic data with the desired pathologies. And here we have an example of enforcing cardiomegaly disease, which is unusually big heart. And you can really see that in the original, you have very usual heart. And in the counterfactual example, what is mostly changed is the heart size. And the remaining anatomy is more or less the same. And the last nice property of this classifier guidance is that we can manipulate the guidance strength to generate images with different disease level. So to sum up, we can generate some additional synthetic data, but we have this additional control over them. Yes, and that were my project related to generative learning. I was involved since I joined Sano. But recently I'm exploring a very dynamically developing research area, neural rendering. And the goal of novel ViewSynthesis is to reconstruct 3D or 4D scene, which is dynamic scene, based on photo collection or video. Then we should be able to view such scene from novel, completely arbitrary point of view. So these techniques have some nice advantages over traditional 2D monitoring, especially for surgical procedures. So we can view surgical site from any viewpoint, which benefits surgical navigation or surgical augmented reality. Such techniques facilitate preoperative planning and, as mentioned before, virtual reality medical training. And if we have such techniques operating in real time, it can also support intraoperative use. It could complete view for surgeons, we could enhance navigation and control of surgical instruments. And finally, it could really increase the potential for robotic surgery automation. And what recently caused such rapid development of reconstruction methods are two types of modeling. First one, called neural radiance fields, was introduced in 2020. It offered very high quality of reconstruction. It uses implicit representation, which is possible thanks to small MLP generating color and density, which is not very important for this seminar. And what is really important that these neural radiance fields methods are very slow to train and to render, which really makes it difficult to utilize such method for surgical cases. And the latest breakthrough was caused by Gaussian splatting 3D, introduced last year, which also offers very high quality of reconstruction. And thanks to this explicit representation, which are basically Gaussian splatted into the image, the training is incredibly fast. Also, the rendering is incredibly fast, reaching this almost real-time speed. And this is something I've been working since a couple of months. And so far, I was involved in more typical computer graphic projects based on Gaussian splatting, mainly for accurate geometry and mesh estimation from non-consistent photo collection. That was the first project. The other one was for mesh-based dynamic scene manipulation. These projects were conducted with Warsaw University of Technology and Wrocław University of Technology. Both of these projects were recently submitted to conferences, to NeurIPS, and to Interconference of Computer Vision. And now my current work in progress is Gaussian splatting for medical scenarios. Unfortunately, I don't have much to show you in this area because, as I said, it's really work in progress. It's not close to any submission. So yes, so that's why only this very brief introduction to this topic. Thank you very much for attention, and I'm happy to answer any questions.
Many thanks for your talk, and well, we have time for discussion. It's time for questions, for suggestions. Maybe before other questions will come, you presented something like split this research into 3 parts. In what could you name as a common, let's say, topic which make a kind of a bridge between all of this research you have presented today?
Yes. So
what is linking this?
Yeah, I think the main link is targeting this limited field of views, this limited data, which we really want to expand in one way or another. So basically, there is one way for generating synthetic data for, of course, some completely different tasks, because mainly for training, pre-training, like my first projects, but still we are targeting this medical data scarcity. And we hope that the outcome of this project can be useful for surgical robotics, for example. So I guess this is the main link. And now I think that there were quite a lot of works, for generative learning, and we kind of reached this point where we decided, okay, maybe that's time to try something really new, which we don't see where we see the gap, where we see problems really not solved in the medical domain, and that's why I got interested in novel ViewSynthesis.
So it is general, let's say, umbrella over all this will be something like generation of synthetic medical data in such a way that they will really mimic reality, yes?
Yes, yes, so, yes, exactly, something like that.
Well, and another question which I have, you have presented this research in a way in which there were many figures and well tables, but I suppose that there is some, let's say, there are some formal methods, maybe somehow linked with probability with statistics. Could you tell something about what type of formalities are behind what you have presented?
So we usually follow the standard evaluation, which is typical for works of that type. So there are not many statistical testing in this type of work, unfortunately, in machine learning. However, we think that this type of evaluation, for example, intersection of real, which is not a statistical method, but we think it's enough to really evaluate the performance of the method in the to really evaluate if our proposed method can be further utilized for some other downstream tasks. So yeah, we just follow the standard procedures, basically.
So, as I understand, at that moment, the main outcome will be elaboration of efficient methods, efficient procedure, and the second is application, but applications are not so important and as purpose of this research as elaboration of this new innovative method, yes?
Yeah, yes.
Okay, so it was me. Let's check who is coming with other questions.
I see the question about training.
Yes, on chat, yes,
Yes.
from Julio.
Yeah, so regarding my first project, Dreambook is quite a quick way to fine-tune models. That's why that's why I refer to it as a smart method, because you don't do the full fine-tuning, and that's why it was possible to actually train several Dreambook models in our NVIDIA in our machines at Sano. That was nothing difficult with that. And my second project required a bit more computational resources, unfortunately, and we see that this is kind of a drawback of this method, of course. But that's how diffusion models work, and for that I utilized Athena. This is it's a Polish grid. We have access from Sano, which was very useful for me, because without that it could really took much longer than it already took. And what is the shape of medical images that you considered in your studies? And I worked. I'm not sure if that's the question, but I worked mostly with RGB images or even grayscale images, and X-rays are usually 1,000 24, but we downsized that to 256 because it was more like a project, to perform proof of concept, to calculate all the metrics, but there is nothing difficult in expanding this dimension to 512, but we just didn't conscious of those limited resources.
Well, thanks, Julia. If you would like to let's say to comment this answer, I think that Mateusz make possible for you to just to speak. So, if you would like, I see that you have already wrote something like "Okay, thank you." So I understand that it was what you wanted. But anyhow, if you would like. No, so let me check once again. Well, Wiesław, well, we have Wiesław Nowinski in the queue to ask the question or to comment. Wiesław, please go on.
Hi, yeah. So, how to put it? When I attend clinical meetings, usually clinicians complain we have data explosion, we have too much data, we are not able to process them, especially to interpret them. You are looking from the data from the other end, meaning there is scarcity of data. Let's say in the first project, laparoscopic surgeries are for a few decades, so there are really tons of data. So the question is, are you solving a real technical problem, or are you trying to compensate for some organizational problems that data are there, but I have no access to the data?
I think that the most important problem because we are aware that there are several, like 50 videos from laparoscopic cholecystectomy in one data set, which makes thousands of frames. The problem is that first of all, those frames are really not labeled anyhow. Sometimes you have just triplets, but it's very, very, very poor label. I mean, it's just triplet of action, like scissors, grasp, scissors, cut, liver. No, it's not the medical term, but anyway, it's a very cool label. So, for example, if we want to train or test medical robot, which needs some additional information about depth, about normal vectors of those surfaces. We don't have them, and we can't really have them because clinicians are not really, maybe segmentations label are quite, let's say that's feasible to obtain. It's not easy, it's not fast, but it's at least feasible to obtain. But there are some labels like normal vectors, which is not feasible to obtain, and I can imagine such scenarios where you just need those additional labels to successfully train this medical robot, or just simply evaluate, because you may have a method which works in those which is trained without those labels, but still it would be nice to at least see more or less how the robot was trained. So yeah, I think that this is real problem where you have lots of data, but they are simply not processed in the way we could benefit from them.
So let's look differently at the issue, because when we are talking about robotics, of course, in Poland, we have, I believe, a few Da Vinci systems. So how they are dealing? Is they are doing laparoscopic surgeries using Da Vinci? Cannot you use this kind of data for your work?
I'll jump in here. So I'm not sure whether we understood the question. I mean, what type of extra data like Da Vinci gives you compared to the laparoscopy?
Yeah, what I have in mind that Da Vinci is a robotic system. So cannot you use data from Da Vinci surgery to your work?
Well, main benefit of Da Vinci in terms of data acquisition is that it has stereoscopic camera, so it's easier to potentially to reconstruct the surgical environment, but it doesn't give you information. So what we are focusing now mainly is basically semantic segmentation, pixel level wise. So Da Vinci does not do this. Like I don't believe they are equipped in any AI systems. You can potentially like read you're not even able to correctly read the position of the instruments in 3D space. There is a bunch of papers that are doing 3D pose estimation of Da Vinci instruments from vision, not from the kinematic data of the robot, because it's just not accurate enough because of the cable drives and so on they use.
So Przemek, does it mean, because I don't know your work in more detail, does it mean that you are trying to develop more advanced, more sophisticated surgical procedures than Da Vinci is able to do?
No, I mean, I'm not entirely sure whether there is a good we understand basically each other. Maybe Asia, can you show some slide what kind of data we are generating, like from the paper? I don't think it was in the presentation, like normal maps and all this. Yeah. Yeah. So you don't have it. I
don't. Oh, maybe I have them here.
Yeah. So for example, if you look at the right side, you can see the top image, the black and white. This is a depth map. So basically, how far the pixel is from the camera. The darker the color, the closer, the brighter, the further from the camera. So this kind of labeling is crucial for all for example, like a safety mechanism during surgery, but also for 3D scene reconstruction to get understanding what's going on. And imagine like manually labeling this, like drawing black and white gradients on the image, because you can't do it other way around. So it's basically even impossible to do it manually. Second image, the semantic segmentation, the color one. So that's more feasible to do it manually, but it's still very tedious. I mean, I can't imagine surgeons, sitting and labeling hundreds, thousands of frames manually, like coloring them pixel by pixel. Of course, there are like semi-automatic ways, but still. And this is rather straightforward image, but if there are images where there are some vessels like going under the tissue, probably you won't be able to get the common ground by many surgeons. Probably, I mean, what I'm trying to say that every surgeon will mark it slightly differently. And there was recently, already after our work, there was a big data set of manual label data from Dresden, and they had 3 surgeons. So you get map different labels from all 3 surgeons, and you also have averaging. And there is more. There are like normal maps, which we don't have here. So it basically shows you the orientation of the surface in respect to the camera. We can get ground truth of optical flow, so how things change from frame to frame. What else, Asia?
We also have labels like actions.
Yes, so this is used. This is a really big thing, this so-called triplets. This is basically a text description, which instrument is what it's doing to which organ. So like grasper retracts liver, diathermy coagulates, I don't know, the fatty tissue, the connective tissue, for example. And there is a lot of research and so-called surgical data science, where they want to automatically assess the surgeon performance and possibly also detect this error, this near misses in surgical video. So you record basically the video of the procedure, and this is automatically analyzed by the AI system that will give feedback on the surgeon performance, on his possibly learning curve, but also if there are there are errors happening. And there's a whole sort of new field, I would say, in the surgery, so surgical data science, like a video analysis. So that's why the labels for now and the data sets you could find, there was this text description. So it basically you could find like a surgical phase, detect what is the surgical phase and more or less what is going. And of course, this is getting more advanced. But for example, for things like if you could go to next slide, I believe. One more, the one with the segmentation. You had this critical view of safety somewhere there.
Mm.
Oh yeah, here. So basically, during cholecystectomy, there is, you can see the triplet on the right. So this is this text description. But on the left, you can see the segmentation, and there is already like a first sort of system, experimental system from Strasbourg. They have this very strong, this IHU issue center for clinical training. That you have a so-called critical view of safety. So basically, to be able to make a safe cut of the vessel of a cystic artery, you need to have like a free sort of plates of organs clearly visible. So basically, the system detects whether there are like a free anatomies visible, and it gives you like a big green marks. Okay, if you have all 3, you're safe to make the cut. So these are basically like an infancy of this AI systems in surgery.
Yeah, so thanks, Przemek. It's getting more and more clear. I don't know if it doesn't make sense, but in case of the brain, when we face problems with this anatomical labeling, we apply brain atlases. Do you think that some organ atlases might be helpful to do labeling? Of course, they should be highly deformable. They should contain organs and vessels. Is this kind of approach useful? Would be useful?
Well, we are not quite there yet. For now, it's sort of black box, I would say. So things get in and get out. But potentially in the future, yes. So I already last couple of weeks ago at Hamlin, they used large language models. So they're trained large language models on basically surgical knowledge on the textbooks, and they try to have like a multimodal understanding of a surgical scenes. So potentially the atlas, including the anatomy atlases, could be also possible as this sort of multimodal approach.
Yeah. Asia showed beautiful synthesized images of textures and so on. Did you verify the quality of those images with any clinicians? Do you have their opinions, how they like them?
No, we had this idea like very early on. Even Natalia Lieb, she made a system like a survey where the clinicians can judge whether the image is synthetic or not, or real. So we just finished like literally last Monday submission to this winter conference on IEEE winter conference on computer vision. And the follow-up will probably include, compared to the regular sort of statistical comparison of the data sets, this FID and KID matrices will also have basically human feedback. I don't know whether Asia you'd like to add anything on this.
Okay, thank you so much and good luck. Very nice project. Beautiful results. Thank you.
Yeah. So are there any questions remaining somewhere? Because I can't see anything on chat. So I think that's it. So I will stop sharing my screen.
Okay.
Oh, Shimon has a question. Is there a possibility for real-time analysis using diffusion models? Where there are some, I'm not sure which project, I mean about real-time GPU-based device like Clara. I'm not sure. I mean, there are some, I'm not sure which project you refer to more. Like, is this like the data generation, which we know there are some works for more real-time data generation. Yeah, something like new Dreambook, which is super lightweight and yeah, and works almost real time. I know about this. I'm not sure about applications like more like my second project, where you have the full model trained for the specific use case, for the specific domain. I'm not sure. These are rather yeah, quite large architectures, and and of course we have different sampling methods and different denoising methods, but I'm not sure if for some additional.
Yeah, so I did some experiments in for image generation. There are these models like Stable Diffusion Turbo or LCM. It's called latent consistency models when they are doing some extra processing, and basically normally you would need something like 20 steps, iterations to generate like a nice image, 20 to 50. With this, you can have between 3 and 4 and maybe even 1 in some models. So you could get something like 5 frames per second currently on basically Clara, on the GPU from Clara, this RTX 6000, not the ADI, not the ADA, the older one. So yes, so it's not fully real time, but it's can be potentially already used in an interactive way, basically.
Yeah, but these are again very specific tools. It's I think, right? These are not like how to say that. Yeah, this is basically like what you tested, Przemek, to generate those data, like yeah, very quick generation. But if you want to utilize this diffusion model for some additional tasks, like I did for classification, I'm not sure whether the possibilities are there already. I'm not sure about that. Yeah.
Well, we have Szymon still with us. Szymon, would you like to add something? Well, no. Szymon is happy with what he heard as an answer to his remark. Well, I'm looking for other questions and discussion. It seems that that's all what we have as a discussion. So many thanks to Joanna for talk, and many thanks for Przemek to explanations, Wiesław and Szymon for discussion. Many thanks. And well, we will have last seminar in this summer semester next week. It will be Michał Motak, also from Health Informatics team. So thank you very much for participation, and looking for seeing you in a week from now. Thank you.
Thank you very much. Have a good day. Bye.
Bye.